Thank you, Chairman. And I thank the organizer and especially thank Dr. Chen for the inviting. So unlike the other four speakers, I told a different story. The PUMCH syndrome is a quite rare plasma disorder. So there's not so much data to present, especially no cytogenetics study or no mechanism studies. I only share our experience on the management of the PUMCH syndrome. The PUMCH syndrome is an abbreviation of these 5 words: polyneuropathy, organomegaly, endocrinopathy, and protein and skin changes. It's believed that it's a rare plasma disorder, and through the M protein and some cytokines, especially the VEGF, caused multiple tissue damage. So the criteria for the diagnosis of the PUMCH syndrome is proposed by dispensary from the Mayo Clinic. It's including the mandatory majority criteria such as the polyneuropathy and the monochrome plasma property disorder, and some other major criteria, and the Castleman and the scleroid bone lesions. And recently, he added the VEGF elevated as the major criteria, and some other minor criteria. So based on that criteria, we summarized our patients. So totally, it's last year's published this paper, and the last year is 99 cases, but I think till now it's over 120 patients. And the middle age is 45 years. I think it's younger than compared to the myeloma patient. But almost every patient is 85% patient underwent the misdiagnosis. The time from onset to diagnosis is 1.5 years. The common initial symptoms, including the peripheral neuropathy and some peripheral edema and the skin changes. So for our group of patients, all the neuropathies were confirmed by the electromyogram. So the neuropathy is dominant characteristic, is a peripheral, ascending, symmetrical, and affecting both sensation and motor function. So compare our group of patients, compare the others reported. One is from Japan and one from the Mayo Clinic. We can see the age is almost the same, and all satisfy the mandatory criteria such as the polyneuropathy and the monochrome M protein. And for the Castleman disease, our patient a little bit lower compared to the other two, but the scleroid bone lesion, our patient is extremely low compared to the other two groups. And for some other endocrinopathy and so skin change and the increased CSF protein and the thrombosis and the M protein, the happiness, the increase almost the same. But there are some difference in our group compared to the other two groups, especially in the Western patient, such as for the organomegaly. We can see our patient is higher compared to the Western people, it's quite low. And for extravascular volume overload, and our patient is extremely higher, and also in Japan is almost the same, but in Western people, and it's quite low. Another aspect, since our patient underwent the long time of the misdiagnosis, so many patients suffer from the pulmonary hypertension and the restrictive lung disease, renal impairment, but in the Mayo Clinic, this is quite low. And we assess the VEGF in our patient, and so we can see the VEGF level is extremely higher, even compared the MM patient is higher compared to the MM patient. So since this is a quite rare disorder, so there's no standard rule for the treatment. Now it's divided to the two groups. The one without disseminated bone involvement, we can use the radiation. But we seldom met of this patient, so we have no experience on that. But most of the patient is disseminated bone marrow involvement. So we apply the systemic therapy. For the systemic therapy, and the principle is applied for the refer to the myeloma, and so including the corticosteroid and the melphalan-based regimen, and including the auto stem cell transplantation. And now recently, there's some report using the novel agents. For the auto stem cell transplantation in 2004, Dr. Dispensary from Mayo Clinic reported the first 16 patients. It shows that the PBSCT for PUMCH syndrome is effective therapy, but may be associated with a significant morbidity. So from the 2005, we enrolled 16 full patients, and the male is predominant. The median age is 44 years. The median time from on-site to transplantation is 2 years. And most of the patients applied the cyclophosphamide plus the GCSF for the mobilization, even though the MNC and the CD34 positive cell eating is almost the same, but we can see the CD34 positive cell eating is a little bit higher combined with the CTX plus the GCSF. So we prefer use the CTS plus GCSF to mobilization. And totally, 62 patients completed apheresis, and 2 patients failed because of the cardiac problem, and 1 because of the severe infection. So unlike the myeloma, the apheresis process is very complicated, and so there's a lot of complication on it. The main problem is the extra volume overload, and it causes the difficulty to apheresis. Some people even suffered the acute renal failure. So, and because some patients have the poor condition, so cannot tolerate cyclophosphamide, so have the neutral fever and some septic shock. So 45 patients received the stem cell transplantation, and 80% received the melphalan 200 milligram, and some because of the bad condition, and they received 140 gram. And so neutrophil and the platelet increment shows no special. For the response, we median follow-up for 17 months, and evaluate 35 patients, and so 10 patients unevaluated because 7 is follow-up less than 3 months, and 3 patients died because of the transplantation. So we can see the hematological response. The CR rate is above the 50%, and the PR got more than 1/3%. So total overall response is over the 90%. For the neuropath response, initially we evaluated by the electromyogram, but we didn't see any difference on it, even though the patient, the symptom and the sign and the better, and even patient can go work, and so still we cannot see any difference by the EMG. So maybe we adapt the other index. So we adapt the overall neuropath limiting scale. It's modified from ODSS as S is for the Guillain-Barré syndrome. So you use that index, we can see all patients got improvement. The median ONLS was decreased from 4 to 1. For patients whose follow-up time for more than 1 year, the ONLS score all less than 3, and no relapse till now. For other response, for acromegaly, we can see more than half patients got improvement, and for extravascular volume overload, and more than 70 patients got improvement. Even though that the response rate is fine, but still there's some treatment-related toxicity. It's much higher compared to the myeloma patient. Except the infection, severe infection, and other toxicity, the most distinguishable the side effect is engraftment syndrome. It happens of almost 25%. It's quite higher compared to MM patient. And the death rate, the transplantation rate, death rate is 60%. 2 suffer from septic shock, 1 and cardiac arrest. And 1 patient died of a TB infection after 1 year of transplantation. So compare the other larger report. The dispensary initially reported 16, and then he added to 14 as 30 patients. And in Japan, there's 12 cases reported. Our report is 45 patients. We can see the red blood cell and the platelet engravement, no special, and the hemorrhagical response is almost the same. The neuropath response, all the this group reached 100%. The death rate, our patient a little bit higher, but these two groups have one cases relapse, but because of our time, follow-up time maybe not enough, longer enough, there's no relapse till now. But we can see many of the patients admitted to the intensive care unit for the treat the side effect, treat the complication. You can see in dispensary, there's a higher rate of the engravement syndrome. And so our patient, because of the space limit and some financial problem, only one patient underwent the intensive care unit. If more patients go there, and I think maybe death rate maybe decrease a little bit. So the treatment-related morbidity and the mortality can be minimized by recognizing and treating an environment-type syndrome. This is the characteristic by fever, rash, diarrhea, weight gain, and the respiratory syndrome and the signs. And it occurs anytime between day 7 and day 15 post-stem cell infusion. So in dispensary's first 16 patients, the rate of ICU admission was nearly 40%, and with early identification of ES and the number of patients being dismissed from hospital after day 24 has decreased from 33 to 8%. So early and sufficient dose of corticosteroid to terminate the ES process is necessary. So since the single transplantation is work, and also refer from the myeloma patient, how about the tandem transplantation? We only have one case finished the tandem transplantation. Till now, she is fine for follow-up for more than 5 years, but there's not enough data to support that. There's only one case report. So today, there's no information about the dose-dependent quantity and the duration of response. So auto stem cell transplantation seems effective and tolerant for the PUMCH syndrome, but not everyone can afford that. But some people, maybe the condition is so bad, and some cannot afford the stem cell transplantation. How about that one? So we use the warfarin and plus dexamethasone MD regimen for the apply for the patient. So this work is published in Broad last year. This is the newly diagnosed patient. This is highly commented by dispensary. This is the first prospective clinical trial in the PUMCH. So it enrolled 31 newly diagnosed patient aged 44, and we used the MD regimen for apply for 12 cycles. You can see the neuropath response decrease, and so on the 15 months, and so decrease stable. And the VEGF also changed gradually, and on 15 months, and so decreased the lowest level. So you can see for the organomegaly and so extravascular volume overload, the response rate is comparable with the stem cell transplantation and the MD regimen. So I think that everyone is familiar with the MD regimen, so it's quite safer. So that's not so much advanced event compared to the stem cell transplantation. The most common one is grade 1 neutropenia and some analysis. So it seems that the MD regimen is effective and well-tolerated for the PUMCH syndrome compared to PBS-CT. But which one is better? I don't know answer. So because the MD regimen, the patient applied 480 milligrams per square to the warfarin and exposed to this warfarin for almost 1 year. And for PBS-CT, it's quite short time, and so only 200 milligrams. So how about the second malignancy, and how about the duration of response? So because we need a longer follow-up. So except the warfarin, there's some case report applied some novel agent. So thalidomide plus dexamethasone is also work, but we worry about the side effect, the peripheral neuropath. So the long time use the thalidomide maybe limit the apply for the POEMS syndrome. The Velcade is also can work. We have applied one cases with the acute renal failure, and so after 3 courses of bortezomib plus the dexamethasone, and quite the extra volume overload and the improvement quickly, and the renal function can return to normal. So there's also some report use the Velcade plus dexamethasone, but how long we use that and how many courses is still no answer, because a long time use that still worrying about peripheral neuropaths. For lenalidomide is a promising one, because that's the French group use the 8 cases, and so it works quite well. So unlike other plasma disorder, so in POEMS syndrome, the VEGF seems play the important role on it. So somebody think that use the anti-VEGF antibody maybe have the effect on it. And there are also some case report use the anti-VEGF antibody. So it also work, but the duration of response didn't last longer, and so needed a further treatment. I think the main arm is focused on the M protein. The survival of the POEMS syndrome is better compared to MM. So we don't worry about the survival. We just worry about the life quality of this patient, because almost this patient is disabled, and some patients stay on the bed. The life quality is quite poor. So the arm of our goal is to improve the life quality of this group of patients. So in conclusion, the POEMS syndrome is a rare plasma disorder, but it has a better response to metformin, either in the form of low-dose convenient therapy or high-dose with stem cell transplantation. The key question is the early recognition of disease, since our patient, almost every patient underwent the misdiagnosis for more than 1 year, and to avoid the irreversible peripheral neuropaths. So I think the group of doctors, especially Dr. Li Jian, has paid a lot of work on it, and so all the nurses, they paid a lot of work on it. And finally, thank all the patients that participate our trial. So thank you.